Anytime we do surgery, we do an evaluation of the risks of the disease we're trying to cure with the operation versus the risks of the surgery itself. And in general, in surgery, we want there to be a favorable risk-benefit balance. That means the risk of the disease needs to outweigh any risks related to the operation. There are standard risks associated with a gastric sleeve operation. Any patient who's being evaluated for surgery and is in the final planning stages has already undergone that evaluation and it is felt to be favorable. Going to go through several problems that can happen after a gastric sleeve. We'll break it up into early problems, which would be the first 7 to 10 days, and then intermediate problems, which would be within the first several months. Fortunately, gastric sleeve has very few long-term problems and almost no long-term emergency problems that require an operation. In the early phase, the first thing we worry about after a gastric sleeve operation is bleeding. This would usually occur within the first 24 hours. This is the main reason why we keep the patient overnight in the hospital. The risk of significant bleeding, in other words, a patient requiring a blood transfusion, is thought to be around 1 in 100. The risk of having to go back to the operating room for bleeding is relatively rare, probably less than 1 in 500 to 1 in 1,000. The next thing we worry about is a leak. This is a hole or a gap along the staple line, which would allow the intestinal juice to get out and would start a bad infection next to the gastric sleeve inside the abdominal space. This is known as peritonitis and is very dangerous. If the patient has a leak, we have to return to the operating room to correct it. That means washing out the infection, closing the hole, and probably placing something on the inside of the sleeve known as an esophageal stent. An esophageal stent is an adjunct to closing the defect in the staple line. It lets it heal up sooner and more reliably. Unfortunately, esophageal stent is not very comfortable and it needs to remain in place approximately 2 to 2.5 weeks, after which it will be removed. According to the literature, the leak rate for a gastric sleeve is approximately 1 in 100. Another early problem that can occur after gastric sleeve are blood clots in the veins of the legs. These are particularly dangerous if it were to break off and travel up the bloodstream to the lung. That's known as a pulmonary embolus. Treating this and diagnosing it afterwards is extremely difficult. Therefore, our strategy is for prevention. We do several things to prevent a blood clot. First thing we do is we give a blood thinner prior to surgery and every 12 hours until the patient leaves the hospital. In addition, we place squeezer devices on the patient's lower extremities that help keep the blood moving around while they're asleep in the operating room. Both of these methods are helpful, but they're not as good as the main strategy for reducing blood clots in the legs, which is to have the patient up and walking within 4 hours of the end of the surgery. Early ambulation is extremely important in reducing the risk of a lower extremity blood clot. Another problem that can occur in the first 7 to 10 days is a wound infection. Wound infections can occur after laparoscopic sleeve surgery. They are fairly rare, occurring in 1 to 2% of patients. If they do occur, though, they need to be treated like any other surgical infection, which means opening up the incision, doing dressing changes, and sending the patient home on antibiotics. These are the main problems that can occur in the first 7 to 10 days after surgery. Intermediate problems can occur within the first few months after a laparoscopic sleeve gastrectomy. In general, these all boil down to the same problem, which is a narrowing somewhere in the sleeve. Within the few first months after a laparoscopic sleeve surgery, during the healing phase, there is scarring and the scars tend to contract. This can lead to a narrowing somewhere in the sleeve. The symptoms from narrowing are almost always the same: nausea and vomiting. If vomiting is persistent, or if the patient is vomiting certain foods he or she should be taking already easily, then they should be evaluated for a narrowing of the sleeve. Narrowings can either be a short segment or a longer segment where the sleeve becomes twisted as it scars down. Short segment narrowings can be addressed by doing an endoscopy or placing a flexible scope down into the sleeve, advancing a balloon dilator into the narrowed area and dilating it, making it larger. This is called a balloon dilatation and is generally very effective, although sometimes serial dilatations are required. Usually 1 or 2 balloon dilatations will result in opening up the sleeve and resolving the symptoms. A longer segment of narrowing or a twist might require a reoperation. This can be done laparoscopically and is very rare. If the patient develops a narrowing that cannot be addressed any other way, there is always an option. That is to revise the patient to a gastric bypass. We can always bring a loop of intestine up above wherever the problem is and attach it, bypassing the problem in the sleeve. Fortunately, the sleeve gastrectomy avoids some of the long-term problems that can happen with the other operations. Some of these problems can result in emergency surgery. The gastric sleeve does not have a vulnerability for ulcers or small bowel obstructions as with the gastric bypass, and there is no foreign body that can slip or erode as with the lap band. Problems occurring several years after the operation, as can happen with the gastric bypass or the lap band, simply do not occur with the laparoscopic sleeve gastrectomy. This is one of the great strengths of the operation, as it has the lowest long-term risk of all the surgeries. If you have any questions or need any other information, please visit our website or call your surgeon's office.